back to the program, and now we're commencing our second conversation. And from studies and research, community health workers are very crucial and supportive link between health and social services, and of course the communities that they serve, from facilitating health care access to improving the well-being of community members. Community health workers provide a service that positively impacts lives of the nation's vulnerable groups especially. So today we will take a brief look at the role of community health practitioners and of course the registration board. Demola.
Yes, we have in the studio to talk more on the role of community health practitioners and its registration board. We have Shiono Benebo, okay, the former registrar, Community Health Practitioner Registration Board of Nigeria. You're welcome to Good Morning Nigeria.
Thank you.
We have Dr. Bashir Idris, also a registrar. You're welcome. Thank you. All right. We have Thomas Sule Galadima, former board chairman, and you're welcome.
Thank you.
And also Bartholomew Nwaboro, right?
Thank you, sir.
Is the Director of Registration and License. You are welcome to Good Morning Nigeria.
Thank you for having me.
All right, so we can kickstart. And you just tell us, who is a community health practitioner and how important are they to the society?
Thank you very much. Nigerians, good morning. I want to thank for opportunity given to our board to be here. As you made mention, we are Community Health Practitioner Registration Board of Nigeria, established by Decree 61 of 1992. Now, the law of federal, it has been enacted, LCP 19, 2004. And we have the mandate to coordinate the training of community workers across Nigeria by determining the skill and the knowledge a practitioners need to have. That is JCHU, CHU, and CHU. And we are the one to conduct a professional exam and certify them with license to practice in the community and any other responsibility tasked by the board. So critically, we are middleman power that we work across Nigeria, most especially in the primary health centers, health clinic, and other health settings in Nigeria to administer preventive, curative, and rehabilitative services. So these are what the board did. That is our role, maybe in brief. And when you look at community health workers in Nigeria, we have more than 300 practitioners across Nigeria that work in different, more than 300,000 community practitioners in Nigeria that work across PSC centers. I tell you now.
Are they mainstream ministry workers, or these are just, private community health workers? I don't know.
Yeah, they are the mainstream. We are not the other Federal Ministry of Health. The Federal Ministry of Health.
Okay.
Yes, we render ourselves in the PSC. When we remove these community workers in Nigeria and health industry, I think it will collapse. Because every community you go to, you see community workers.
So how do you recognize them? Because when you go to the primary health centers, I mean,
everybody
is a health worker. You're either a nurse or whatever. So is there a particular way of knowing who is a community health worker?
Yes, the only way you can differentiate, we are all health workers. Probably we use the same uniform, but there are some differentiation for community health workers. We use white and ash. And we have our ID card license to practice attached. That's the only way you can be able to differentiate. Because when you go to every teaching hospital, you see doctor wearing coat, lab technician wearing coat, pharmacy wearing. The only differentiation is the service we render and our identification the last we work in the PSC. Because we make the bulk of workers in our primary health centers by our services. Let me cast a little back. After the Alma-Ata Declaration in 1978, whereby all the countries, 78 countries that were there, declared PSC as the cornerstone to implement PSC across the world. Then that was then the era of the President Ibrahim Babangida. Then the same scheme was launched in 1988 in Nigeria, whereby that was bring about the birth of community health workers, creating School of Health Technology in all the states to train this cadre of personnel to go to the rural areas. Because doctors and nurses, they say they are not ready to go and work in the bush. They cannot satisfy their good road and whatever. Then community workers were trained. They have to go right from the background in your training. After you qualify, You go to the rural areas and work. That's why our name is community health workers.
Okay.
We've been selected from the community. We come from the community. We work for the community, and our name is community health workers. That's how our name come about. Because you know when you go, you have to go back to the community.
Like, do you post people back to the community where you recruited them
we
from?
selected them from the community and post them to train. After graduating from the school, they go back to the community. Yeah, okay. The same thing what happened to me before I became a registrar. I was speaking from my community.
Okay.
Went on the take the training. After you completion that training, go back to the community because you know the terrain, you know the community.
How do you do your selection process? How do you select them from the community?
From the bottom, from the community. We look at the need assessment. What are the community that don't have much manpower? Okay. And what are the people around that area? Then they will select it. Okay, Girim was ABC, we'll take them to the school. Because right from the local government, the selection from the political vote, from the district, they pick people and posted them to train. After the training, then they go back and work.
Sorry, we will soon expand the conversation. We just like to get the business. Do you just, because you are saying you pick people,
yeah.
He has asked you selection,
yes.
And you say you pick people. Do you just, maybe you just come to my community, or you just come to this community of the studio now, and you just say, okay, Femi, who is the studio
or you liaise with the community leaders.
You know,
community leaders and select people that have the basic requirement.
Do they have to have certain degree of skill, you know, related to health, or just maybe school side, or I don't know.
What's the qualification?
We select them based on their what? The need and their qualification. Okay. They must be science oriented. They must have 5 credits, including all the basic requirements for admission into university. Then they will be picked. Then to go to School of Health Technology or College of Health Technology. For JHU, you spend 2 years. For CHU, they spend 3 years. Then after, there are other post-training up to the BSc level.
Beautiful, Dr. Idris. Thank you. Let's expand the conversation now and bring in. I just like to bring in Shiono Benibo, who is the former registrar. And I'm just wondering, in terms of responsibilities and roles, we know what the nurses do. We know what the doctors do. Are there specific duties and responsibilities that community health workers do in the primary health centers?
Thank you very much. Let me say that if you follow the Act establishing the various professional health professions, there seem to be some similarities, but that notwithstanding, we know our distinct responsibilities and sphere of practice. The community health practitioners, by their training, taking a cue from what the registrar have just said, if you go back to the origin, are people that were trained because of the circumstance of the environment where they work to have more skills so as to be able to attend to the various health needs that come across their way. And therefore, their responsibility cuts across promotive function, preventive function.
So you can have midwives?
No.
Birth attendants?
No. Let's not mix the terminology, because we are not here as nursing and midwifery council. So we cannot talk about midwives.
Okay. So
we are specifically community health practitioners.
Okay.
But by the nature of our work and where we find ourselves, our training encapsulates skills from some of these other sub-professional groups. For instance, you talk about midwifery. A well-trained community health practitioner is empowered to carry out normal delivery, to take normal delivery, to manage normal labor. But because of the tool we are using, which is the standing order, which guides the scope of work that any health practitioner will do, if the condition is beyond that particular level of your training, you are required to transfer to the next level. So the JHU has a scope of what they can do, The CHUs have a scope of what they can do. The CHOs have a scope of what they can do. And all of these are defined in the standing order. So, like I said earlier on, the services that the community health practitioner renders are both promotive, preventive, curative, rehabilitative.
Okay.
The complexity in the health system is what has made the efficacy of this category of workers appear as if they are not doing anything, because even when they are functioning, like when we came in now, you are saying when we get to the health facility with everybody working, how do you know who is who? And that is the challenge, because oftentimes the duties performed by the community health practitioner, the achievement gained by their activities are credited to other health professionals because of these misconceptions. And we just hope that with more enlightenment and education,
Okay.
there will be clarity to some of these
Okay. Thank you for bringing clarity to some of the activities of the health community health practitioner. Let's look at the standard and quality now. How do you ensure that it's of the community health practitioners are working, they have the quality, and they are, you ensure standard? Let me ask Mr. Bartholomew, because you are in charge, you are the director of registration and license. How do you ensure quality and standard?
Yeah. Thank you so much for this important question. The Community Health Practitioner Registration Board, as a regulatory body, our core mandate is to regulate the training and practice of community health in Nigeria. And in order to maintain the standard, we make sure, first of all, that training institutions, that is schools and colleges of health technology, meet the accreditation requirement needed to train this cadre of healthcare professionals. Then after the training successfully, exams are conducted by the board, and successful candidates are certificated. Upon certification, my department, the registration and license department, licenses those that are successful in the final professional examination. And in order to follow up, to make sure that standards are being maintained, often and on, we go on supervisory visit to healthcare facilities.
Okay.
And even the schools and colleges of health technology, we don't just leave them without being monitored. We carry out periodic spot checks to make sure that standard of training are being maintained. And we cannot, as a regulatory body, license anybody who don't meet the requirement, going through the rigorous process of training, sitting for our examination, before we can license them to practice.
Okay, let's bring in Sule Galadima, who is the former board chairman now, to speak on one or two issues. And when you talk about community health practitioners, I think my mind suddenly went back to those days when you see, not those days, it's still happening, when you see some people, going within communities, to deliver immunization. They come, they knock on your door, they ask how many children do you have and all that. I want to believe those are, members of community health practitioners. So, and sometimes I take time to ask, this group of people, when they render this service, how do you do it? You mean you walk the whole, length and breadth of this community, rendering this service? So you really cannot, quantify the value of the services they render. So what are you doing to really, restructure and give these people, these practitioners, the value of the services they so, desire?
Thank you for having me this morning, and good morning, Nigerians.
As community health practitioners is being trained, we have community-based function. And in community-based function, as one of its function, even in the training, is how you see them going from house to house doing this immunization. And community health are trained to deliver primary health care components.
Precisely.
So primary health care component, one of the key components is immunization. Curative, as he mentioned. In that curative, you manage common diseases and infections in the communities. Because of the training that was that every one of us went through, you observe that we are meant to go to where people live and work.
Okay.
NK is a community. Lugbe is a community. Go to other settlements within Abuja, they are community. It doesn't really mean only in the rural area.
Yes, I understand. Sorry, I need to clarify so that you can respond within our time frame quickly.
Okay.
I understand that. What I'm saying is that these are the people that we see in the communities, and each time you see them, they look wretched. They look, somehow unkept and all that. And this is not what I mean. The appearance of these practitioners, do not are not commensurate with the kind of services. Yes. So how are you, what are you doing to ensure that they get, the required value for the services they are rendering?
So, for now, just as we earlier mentioned, that this is a agency, a parastatal under the Federal Ministry of Health. And because they are under the Federal Ministry of Health, they both produce the human resource. The absorption is made by the National Primary Health Care Development or the State Primary Health Care Development. So for their welfare, their welfare depends on where they are employed to work. And the government, the government engage them, they pay them all the needed allowances.
Okay.
Like, because of the hazard involved. They take hazard allowances. They take inducement allowances. And even as they go out, the National Primary Health Care give them, every one of them, allowances to go out for this immunization. Though it may not be commensurate with the kind of job they do. But because of the sacrificial inbuilt, which is also part of the training, which one of our logo is that the health of our patient is our first consideration. If there is any other thing, we consider the health of our patient first. And that is why you see even in the risk area, they go and give this immunization where people live and work. Then concerning the incentive again, we know human desire is unsatisfiable. But we are still moving in such a way that the government should know the impact that these professionals are putting in, so that they can be also consider if there is any way they can motivate them further.
Okay.
Quite all right, in health sector, people are running from here and there because of the...
I was going to ask Dr. Idris that question. Before I ask that question, I want to, because your members, they go from one community to the other. I've seen them in churches, I've seen them in mosques, I've seen them in some local communities. They just come in, we're having meetings, and they say we have come to do what's it called now, immunization for the children. Do you, before you embark on search, do you inform the communities that we are coming, or maybe the organization that we are coming to your institution today to do immunization and all that? Because we just see them, we just come in and they say we want to do immunization on a Sunday morning, we're having service, that kind of a thing. Do you? Because some churches will just say no, you didn't inform us and all that. Then secondly, the issue of exodus, people jackpying. Most of the health workers have left. So does it affect your own, what is it called now?
Okay. Thank you very much. Yeah, before I respond, I will respond to first your question that you asked my chairman pertaining people that go to the community looking wretched like this. Actually, people during immunization this era, you know, there are polio campaigns. And during the polio campaigns, there are what we call the chief's agents. There are people that have been trained. Polio is not other technical to drop it. So there are some people that are recruited within the community. They are not community workers. Okay. But the community workers supervise their work. So when you see them looking wretched with no uniform, they are not community workers. They are people recruited for that purpose. Because there are what we call, National Primary Care has what we call chief agent. They will recruit certain people, train them how to drop polio entirely. They are not community, but the community supervises their activities. Because my board chairman mentioned they have 3 functions: community-based, clinical-based, and administrative. As a community worker, you have that function. Okay. Part of your community-based function, you need to go to the community. Then I'll come back to your questions. Before you embark on this polio immunization or whatever campaign, be it a malaria campaign, whatever meningitis, you need to plan effective mobilization, engage the community, and inform the community, whether churches or mosques. You need to tell them we are coming so date for so immunization. So they need to be informed. Sometimes there are misinformation because we have a social mobilization committee at the local government. Any activity going to undertake in that community, they need to be informed before time. So they do that one. Then the other question you asked me, issue of Java syndrome. Actually, we have it, but not much. Okay. But not much. Our people don't go out much. It's a few, not compared to nurses and medical doctors. And the only thing we have more challenge in community worker, we had a shortfall. Let me just give you a simple analysis. Take Abuja State. Abuja State now, they need more than 11,000 community workers. By their period, they only have 1,000 plus. Take Adamawa, northeast. They need about 13,000 community workers. What they have is 1,000 plus. Come to Zamfara. Zamfara, they need about 13,000 plus community workers. But the only one they are now is not less than 900 plus. So for us, we have the human resource now. The only thing we're advocating for state government to make a policy or a plan for replacement. People are retiring. People natural cause is making them to die, to maybe die and whatever other thing. Because we have enough community workers in Nigeria that can address those issues. Some are recruited as volunteers in our PSC facility. You see them working and they will be paying stipend. We thank the federal government for introducing the basic health care provision fund they are using to augment community workers at the primary health facility. So these are community workers. So I hope you have gotten my answer.
We have to interrupt you because our time is far spent. Really, I hope that you'll be able to come back again.
Yes.
So that we can have a fuller, conversation. Because this is a lot of you. You can imagine Demola and I, are just asking questions because we are just learning. Yes. We hear community health practitioners, but it will be good to also expand the conversation.
Yes, yes.
So let me quickly appreciate all of you for coming to share this perspective with us. Sule Galadima, who is former board chairman. We'd like to thank you very much, sir. Shiono Benibo, thank you. And of course, Bartolome Nwapuru, thank you very much for coming.
Thank you so much.
All right, and that's Good Morning Nigeria for today. We thank you for watching. Goodbye.
Thank you. Thank you.
All right.